Great.
Excellent.
So thank you everyone for joining this morning. We have got a talk following the lightning learning format on how to talk to patients about medically unexplained symptoms with Meg, who is one of our clinical psychologists at St George's Hospital. Just before we start, just a reminder to everyone to please fill in the feedback for Meg. I've just placed that in the chat bar and I'll pop that in again at the end. And if you're interested in learning more or accessing more education, then there's also the link to the London School of Paediatrics online learning link there, which links to things like the YouTube channel, the learning pack, and other resources. So lots to learn from our mental health week, so access that there. So I'll hand over to Meg. Thank you so much for doing the talk for us this morning, Meg.
Thanks, Emma. So I've called this tips, and I guess that's really all we can do in less than 15 minutes is kind of do a whistle-stop tour through some tips and ideas from a sort of psychologist perspective, having worked. So I work in general outpatients and on the inpatient ward at St George's. And so over my time there, you see some very interesting presentations, and obviously psychology often gets involved with these patients. So these are sort of some tips from our team on how we think is the best way of sort of communicating with these types of families. So first things first is before you even enter into a consultation with these sorts of families, one thing we recognize is that you need to almost know your own blind spots and what you bring to the communication even before the family have arrived. So how comfortable are you in recognizing and diagnosing these types of symptoms in these types of patients? Are you more inclined to perceive bodily symptoms indicative of underlying pathology? I'm sorry, I can't see that part of my screen. Hang on, if I close that. Right. There we go. How does the what if scenario sit with you? Everyone knows in medicine there is that anxiety of missing something at some point. That one investigation that you could do that would rule out something quite rare. How comfortable are you sitting with the idea of not doing that investigation and sitting with the what if? How comfortable are you at having conversations around things that are more unknown rather than things that are known? Do you prefer to say yes to families rather than no's? Very difficult to often say no to investigations to a family that really, really want you to continue investigating. And how do these patients make you feel? Do they make you feel frustrated? Do they make you feel anxious? Do they make you feel confused? I mean, I know I've experienced a range of emotions working with these types of families. And I guess how has your feeling influenced your interaction and decision-making process? So I guess it's really important to reflect on kind of what you're bringing to the communication and interaction. So my next top tip is sell the biopsychosocial approach and do it early. Okay. So the biopsychosocial model of medicine is a really helpful tool, and I guess one that is more and more popular in the way we communicate to families about their presenting problems, whether they're medically unexplained or whether they're more sort of physiological pathology to them. So we say introduce it early and help them understand the brain-body connection. And I almost talk about it as you're really selling something to the young people in the family, because if you can really get them on board with the understanding that physical symptoms are not always caused by an underlying pathology, then the rest of your assessment, the rest of your treatment process is going to be much easier. And I've put on here two sort of pages from our leaflet that talk about kind of some of the language that we use to help explain the kind of body-brain connection and the incorrect messages. And we use a sort of there's lots of different metaphors out there for a sort of hardware or a software problem. I've put my email address at the beginning of the presentation if anyone wants to email and find out more about the kind of different metaphors you can use when talking to the families about this. yeah, key messages: do it early. A very important thing is validating that you believe that their symptoms are real. So it doesn't matter how obscure, it doesn't matter how inconsistent the patient is presenting with their symptoms. It's really important that you validate that it must be really difficult experiencing the symptoms that they're experiencing. And as part of your assessment, you know, as psychologists, we would recommend you having some curiosity about the kind of 3 different elements that would make up this model. What are their physical symptoms? Where does it hurt? How frequently does it change? What might lead to those changes? From the psychological perspective, we're interested in what impact do those symptoms have on their mood? Have they become fearful of pain? Do they anticipate it? What impact has that had on the way they behave? Have they become more withdrawn? How are they feeling? And then from the social perspective, it's kind of what impact is it starting to have on their day-to-day functioning and their interactions with others, with school? What's their attendance like? What's going on for them at school? Do they find school hard? What's going on with their friendship groups? Are they engaging in kind of healthy relationships with others? And so on. Now, I know that that is impossible to do in a 10, 15, 20-minute appointment or however long you get. But, you know, whatever, if you're able to demonstrate in kind of a willingness to look into not just the physical sides of things, but also the kind of psychological and social, again, you're selling the biopsychosocial approach from an early perspective, because then if down the road it does turn out to look like medically unexplained symptoms, you've been peppering the assessment with the idea that these symptoms could be related to things that are not organic in nature. And another top tip here is try to help the family to identify the factors rather than identifying them for them. You know, there's very often I will be referred, at the point of referring to psychology, I will go to the ward and find the parents are quite cross, and they say to me, the doctor says that, you know, these symptoms are just because she's anxious about her exams. She loves school. She's not anxious about her exams. She loves exams. And at that point, you can see that, you know, it probably is to do with stress. But the family haven't identified that factor. The medical team have identified that for them, and they're not on board. So try and help the family to get there without putting the words in their mouth if you can. Another top tip, and one that you'll probably all be aware of, is avoid under as well as over investigation. I mean, it sounds easy, right? But I guess that the idea is that you've got to try and perform relevant but a finite number of investigations that are needed. And we all know that unnecessary investigations only tend to reinforce a medical cause and lead to more worry for the family and can cause poor treatment outcomes down the road. But this is difficult. You're walking a very fine line. It's tricky. And I guess, you know, one thing that we're learning at St. George's is that talking to your colleagues, sharing your thinking, getting feedback on your investigation plan from your colleagues, learn from previous cases. And another really helpful tip, which I didn't put on here actually, is, you know, joint working. Do this with your colleagues. Do this with your psychology colleagues. Get a consult if you're not sure. And one thing, you know, that I think is, if you can, and obviously it depends on the family that you're working with, is when you make the decision to no longer do any more investigations, sell the good news to the family. You know, it's a really good thing that no longer need to do any physical investigations. It means there's nothing seriously wrong going on. And then we redirect them to the biopsychosocial management plan. And again, having peppered the assessment process with that biopsychosocial approach, that then makes it easier for the families to think about a way forward using it. So a key trick there then is trying to shift their focus away from the cause to focusing on the management. And that needs to be a biopsychosocial approach. The research is really clear that one thing we need to help parents to do is, when we get parents really on board with the persistent physical symptoms or medically unexplained diagnosis, and being clear with that language, is help the young people redirect their focus of attention away from the physical symptoms and the cause, because it only keeps them stuck. Instead, we need to promote a focus on improving their day-to-day functioning and getting back to their normal way of living, and helping scaffold that a little bit for them, identifying achievable steps forward. And we've got some sort of top tips here on how to reset your brain body messages. Refer at this stage to other colleagues who work in the biopsychosocial approach. And depending on the physical symptoms, that might be psychology, that might be dietetics. And one model of working that we're trying to kind of really improve at St George's is consider joint working. Often we find that if, you know, a medical professional and a psychologist, or a psychologist and a dietitian are in the same room, all singing from the same hymn sheet, it's easier for the family to kind of get involved with the biopsychosocial management plan. And at this point, I guess my tip for sort of you as medical professionals is, you know, it's really important the families don't feel misunderstood, that we have to really listen to their concerns. And it's important as well that they don't feel abandoned. You know, once the confirmed diagnosis is made of medically unexplained symptoms, it's not just about signposting them to someone else and saying this is no longer a medical concern. Actually, we need to sort of be working alongside these families, because they are experiencing physical symptoms. The other key thing is they need to feel hopeful. You know, we need to be selling hope to these families. So, take home messages. Know your blind spots. Sell the biopsychosocial approach and do it early as you can, peppering it all throughout your assessment, all throughout your conversations with the young person and the family. We have to get the family on board with that way of working. And it's a new approach. You know, when we think about it, parents, young people come to a doctor and they expect to have a medical kind of outcome. This is new work for them. This is a new way of working, and we have to sell it. So next, avoid under as well as over investigation. Shift your focus away from cause to the management. And then finally, I guess my top 5 tips: practice, practice, practice your explanation of the body-brain connection. I don't know how many of you, I mean, I've walked into interactions with patients early on and I've kicked myself because I've just stumbled over my words. I've had to really blag it. But I guess, you know, it is just about practicing in the mirror, practicing with your colleagues. How is the best way to explain the body-brain connection that can explain medically unexplained symptoms like pain when we don't understand why the pain is there? You know, have you got a good understanding of the gate theory of pain, for example? Can you rattle that off? Can you rattle off the idea that emotions and stress have an impact on the physical pathways of the pain sensors and nerves? You know, it's getting to grips with a really good explanation that you can sell to the family. My second top tip is offer validation and sympathy for their difficulties. You know, you can often sometimes get a bit sort of blaming of these families. They can, or frustrated with these families because they often get very stuck in their physical symptoms. But actually, you know, of course they wouldn't choose to feel this way. It must be awful. So we need to offer, you know, appropriate validation and sympathy for what they're going through. I guess linked with the first tip is be confident. There's nothing more reassuring than a doctor confidently explaining what medically unexplained symptoms are and selling, you know, hope to the family. Fourth tip, joint work with other professionals. It's much easier when you're all in it together. And lastly, model hope. I think that's sometimes what these families lack the most. You know, they come to the doctor in the hope of having a a cure, a remedy, a physiological kind of treatment approach, a tablet to take, something to try that will somehow diminish their symptoms. And essentially what we're revealing to them when we tell them it's medically unexplained symptoms is there's no easy tablet to take. And that can be very disheartening for young people who want the easy way through the problem, not what they perceive to be the hard way through the problem of living with the symptoms. So we have to model hope and optimism that things will improve. And that might then just give them the encouragement they need to try different kind of approaches to overcoming the problem. Okay, well, that's me, just slightly over.
Thank you, Meg. That was so succinct. Really appreciate that. If anyone wants to pop any questions for Meg in the chat bar, we'll just give people a couple of minutes to kind of to take the time to think of some questions they'd like to answer. They'd like answered. And we'll take it from there. One source that I found it's quite useful in terms of getting the explanation of the body-brain connection, and particularly like pain. There's a great YouTube video that was called The Blazing Guns. I know Dr. Etheridge uses it a lot, but that's a great video of explaining how persistent pain can develop in the absence of an organic cause.
Yeah, great.
So yeah, just exposing yourself to lots of different sources can really help you to hone that in. You can recommend that. Lovely. So you've got a question in the chat bar. Could you want me to read it to you? Can you see it? Or
I can see it. I can see it. So in the virtual era of clinics, if we have a patient with the professionals still have MUS and not a pathological condition, how can we prevent over-investigation? We're all worried about missing pathology. Yeah, I mean, it's so tough. It is so tough, Claire. I don't really know how to answer that question. I think we're moving forward in that. I think we're understanding MUS so much more now than we ever have previously. And I think we're getting a better understanding of how to positively diagnose it rather than diagnose it through kind of ruling out other underlying causes. I guess it's about trying to do a detailed sort of verbal assessment as you possibly can, looking at the biopsychosocial, kind of seeing if the picture fits with what you would know to positively diagnose MUS. But yeah, in the video era, I think it is really hard. I guess my advice is talk to your colleagues, get a second opinion.
Yeah. In terms of so that from my own kind of personal experience, one of the things that I would recommend is you can have like a dual approach. So I had a patient who it was really quite likely that they had medically unexplained symptoms, and so during COVID, when obviously I can't see that patient, I can't do the examination, and actually there was nothing there that was making me jump to do an urgent investigation in that period. But actually a lot of the things that you can recommend for a young person who's experiencing pain or fatigue are things that wouldn't be harmful if there was an alternative diagnosis there. So as long as you've kind of explored those red flags, you can still recommend the biopsychosocial approach, perhaps coming back to those conditions. I
would add to that as well. You should be selling the biopsychosocial approach even if there isn't an organic pathology, because
agree.
We're referred patients in psychology to people with organic problems, of course, with chronic pain that has a physiological cause. And there is still a biopsychosocial management plan for those conditions. So when we're talking about cell, it's selling the biopsychosocial approach to all kind of treatment plans. There may be some medical parts of the plan, but there may also always be some dietetic parts, some interventions at schools, some interventions with psychology. So doing it early is my tip for cell. I just wanted to know that YouTube video, Emma. The one
it's called Blazing Guns, and it's chronic pain. If you give me 2 ticks, I can pop it in the chat bar. There we go. Lovely, fab. So just lots of thank yous and thanks for helpful, lots of thanks for the helpful tips, Meg, in the chat bar. So that's great.
Great.
Fantastic. Thank you so much. I took so much away from that myself. That was brilliant. Fingers crossed we get some. Please remember to fill in the feedback form for those of you that are still logged on, and hopefully we'll get you some feedback for you. But that was great. Thank you.
Great. Thanks, Emma.
Thanks. Bye.
All right. See ya.